Hello guys, am I audible and visible? Hello Lion, hello Nayak. Hope you can see me and hear me. If so, say me a hi and a hello. Okay, I am able to see myself, so I think you are able to see me as well. So welcome back once again to one more session of RRR series. So we did quite a few things about acute inflammation the previous two few lectures. We saw about the process of acute inflammation. We saw about the inflammatory mediators. We saw about the respiratory burst as well, right? In today's lecture, we are going to go with chronic inflammation. Good evening, Freaky Nishant. Good name. So we'll have to look at chronic inflammation. Namaste Lalit. So before today's lecture, Lalit, you're going to teach me a word. Yesterday you taught me Sasfulna. I'll never forget that, right? Many more happy returns of the day, and hope you'll have an amazing year ahead and for your future as well. Good evening, but now let's go to chronic inflammation. As we started, we know that cell of chronic inflammation is macrophage, right? Good evening, Praneeth. So when you have chronic inflammation, which is primarily due to macrophages, we have to understand about macrophages. Then we can easily understand chronic inflammation, right? I'm sure all of us know about macrophages. What is the function of any macrophage? What we know? What's the function of macrophage? It's simple, right? Phagocytosis, right? So when I have macrophages, I have multiple effects in multiple parts of the body. So with respect to inflammation, okay? With respect to inflammation, I have two different types of macrophages. One is completely a normal macrophage, which all of us know the function of every normal macrophage is phagocytosis. It's going to eat, it's going to destroy whatever it comes across. I always consider me as a macrophage, all human beings as macrophage. We'll eat, we know to eat, and the only thing what we do is eat, and we'll eat everything what is tasty, and we'll never know when to stop eating, right? The same thing. But phagocytosis means it's going to eat, it's going to engulf. Phago is eating, cyto is cell, it eats every cell, live, dead, whatever is being opsonized, right? I have one more group of macrophages called as activated macrophages. We have to know about activated macrophages, then it's much more comfortable for us to learn about chronic inflammation, right? Macrophage, normal macrophage, the function is phagocytosis, which also is involved in inflammation. And like Fun with Dhruv said, activated macrophages are of two types, M1 and M2 subtype. Perfect, Dhruv. So the function here is secretion. They secrete substances, they secrete interleukins, they secrete cytokines, which makes the inflammation much more effective and chronic, right? They do not phagocytose, they secrete. There are two types of activated macrophages. We have M1 and we have M2. Or we give one more name, we call them classical and alternate. Like your complement cascade, I have a classical or an M1 pathway and alternate or an M2 pathway, right? First, we have to learn how does this M1 and M2 become. Good evening, Kamran. When you have a normal macrophage, it has to move to either M1 or M2, right? So when I say M1, that's a classical activated macrophage and the function is perfectly secretion, that's all, right? What makes them get converted to M1 is whenever any normal macrophage is being exposed to interferon gamma. IFN stands for interferon gamma. When it's exposed to interferon gamma, it will convert to M1 or a classically activated macrophage. And this function is, their primary function is chronic inflammation. They're primarily going to help in chronic inflammatory process, right? On the other hand, when you have interleukin 4 or interleukin 13, it becomes alternate or an M2 activated macrophages. M2's primary function is to heal. It's anti-inflammatory. It's going to help to heal, right? That's a primary function of M2, right? Now let's see. I had a normal macrophage. Some random process gave me interferon gamma. It, like I said, is going to help in inflammation, right? Good evening, Sri. Good evening, Mohammed. So it's going to help in inflammation, that's all. So it does two things. One, it helps in production of more reactive oxygen species. Can I say reactive oxygen species can destroy the bacteria, viruses, whatever we're encountering? So reactive oxygen species can help in destroying the bacteria, organisms, which my acute inflammation was not able to kill. So that's the first tool, right? Second, it will give interleukins. This interleukins, it's like a fuel, it's like a petrol. It puts on the fire, that's inflammation, makes it burn for a long time. So it brings more and more and more WBC and makes the inflammation sustain for like days, months or years together, right? This is what happens in M1. We look at M2 sometime later, fine. Rajesh, I teach at PW Meded. If you're an MBBS student, you can download the Meded app. and there'll be some of you to help you out there, fine. Okay, look at M2 when we discuss about healing process, maybe sometime next week, right? Now we'll concentrate only on M1. That's our goal, fine. Okay, I hope this part is clear. Normal macrophage interferon gamma becomes M1. M1 secretes more reactive oxygen species and more interleukins to make it chronic, right? Now let's go to the chronic inflammation. The prototype is tuberculosis. If you're a medical student, not knowing TB, each and everything about TB is a crime. You have to know about TB because our government has an ambitious thing that we have to eradicate TB by 2030, and that is only possible when you guys and all of us know each and everything about tuberculosis, right? So prototype of chronic inflammation is tuberculosis. Let's see what happens. Let's assume a person inhales tuberculosis. The route of infection for tuberculosis is inhalation. Someone coughs the Mycobacterium tuberculosis in the air, I inhale the air, right? It goes to the lungs. Am I right in saying that lungs will have pulmonary alveolar macrophages? Do they or they don't? They do, right? We have something called pulmonary alveolar macrophages. So what happens is when a tubercle bacilli goes to the lungs macrophage. These are nothing but lungs pulmonary alveolar macrophage. Every organ will have macrophages. I'll have pulmonary alveolar macrophages, right? So these pulmonary alveolar macrophages is going to eat the tubercle bacilli. But unfortunately, TB has the capacity to stop phagolysosome formation. TB has the capacity to abolish the acid pH. In other words, TB is one bacteria which can survive and divide inside the macrophage. That's a problem for me. TB has a capacity where it can go inside a macrophage and can divide. So now you tell me, the macrophage is becoming inefficient, right? Am I right in saying that? Macrophage thought that I can eat the bacteria, it's like simple streptococcus, I can destroy it. No, it's not able to destroy it. Let's assume you are in the situation of a macrophage. You're normally excelling in something. You're not able to do that. Will you panic and ask for help? Obviously, right? We'll just panic and we'll say, please someone help me. The same thing macrophage does. So I'm not able to destroy the bacteria. Let me ask for the help. We have a helper cell in our body. What is the name? We have CD4 T helper cell, right? So that comes and helps. So I have to give signal to the CD4 T helper cell. Otherwise, CD4 T helper cell cannot come and help me, right? So what it does is, this macrophage are also antigen presenting cells. I'm sure you must have read about antigen presenting cells in your first year of MBBS. Can anyone comment what MHC molecule do they have? It's there in the screen also. What MHC molecule as antigen presenting cell have? They have MHC type 2. So they will have help of MHC type 2. It gives signal to my CD4 T helper cells. They connect. That's a signaling molecule for me. They connect together and they will present the processed TB antigen. It's antigen presenting cell. It will process the antigen and give it to it. So T helper cell will now identify the TB antigen. I know, okay, there is a problem here. Let me get activated, and it gets activated into a subtype called as an TH1 subtype. There are three ways of activation. For now, we'll remember TH1 subtype. Freaking Nishant, do let me know later. I'll definitely explain that. Fine. Definitely, Lalit. Slowly. I'll speak a little bit slowly. So TH1 subtype it becomes, right? So it became TH1 subtype. That's one subtype of CD4's activation, right? This TH1 subtype can secrete interferon gamma. Where did we read interferon gamma? Interferon gamma, what does it do? It helps in the conversion of normal macrophage into M1 classically activated macrophage, right? So the normal macrophage here became the activated macrophage M1 subtype, right? Perfect. That's what we had the base of. Now it became an M1 activated macrophage, and we just now learned the function of M1 activated macrophage is not phagocytosis. They will secrete. What do they secrete? Again, just now we saw it secretes more amount of reactive oxygen species in a hope they will kill the TB bacilli. To kill, I hope that it will kill the TB bacilli. Second, it also secretes interleukins. It gives interleukin 1, interleukin 12 and few other. These are two primarily interleukin, right? So this interleukin 1 will attract more lymphocytes. The function is here is very, very simple. They're going to attract more lymphocytes. Okay, let's assume that more T cell came here. Am I right in saying that this T cell should now become TH1 subtype? Yes or no? For my uh, process to be very efficient, this T cell should become Th1 subtype, right? Because only Th1 will give interferon gamma, which can convert activated macrophages. So this conversion also requires a help. That is my interleukin 12. Okay, with the help of interleukin 12, a T cell becomes Th1 subtype. Then it will again produce interferon gamma. It will again convert macrophage to activated macrophage. It will again produce interleukin 1 and interleukin 12. So this process is very simple. My macrophage was not able to destroy TB baseline. It's like a real life scenario. If you want to hit some of your friend, you're in a fight, you're not able to hit them. What do? You phone a friend and say, I need to hit them, please come over. That's what we do. Just an analogy, right? It's the same thing. Macrophage was not able to kill a TB baseline. So it brought more and more and more and more lymphocytes, and it will make sure the TB baseline will be destroyed by activating a complex mechanism. So this entire cell group is what forms the granuloma. Fine. Okay. Tricky Nishant, coming to your question, this per se, let's assume the end of this granuloma, we'll have this how a granuloma looks like. Can I say there are easily 1,000 cells, hundreds of cells here? Easily, right? So I'm having hundreds of cells, and all these cells are going to produce interleukins reactive oxygen species. Can this itself destroy the lung parenchyma? Yes or no? Happy person, good evening. They can destroy, right? So just the bacteria alone can definitely destroy, or the granuloma alone can definitely destroy the lung tissue destruction. That itself can cause hemoptysis. That itself can cause blood and cough, right? So TB per se can cause hemoptysis, that is blood in the sputum or mucus in the sputum. When I give an antibacterial, that also will destroy the bacteria. So it's a huge amount of bacteria, and my destruction is ongoing. Generally, in the initial part of ATT, you will have more destruction, more damage, might be having hemoptysis. But after a couple of weeks, everything will settle because my ATT will clear the organism. Initially, it's a fight. It's a fight between my immunity and the bacteria, it will die. Lung will die. Fight between antibiotics and the bacteria, lung will die. That's why I have the destruction. Fine. I hope the doubt is clear. Good evening, Rahul. Okay. Now we know about the granuloma formation. Right? Please tell me, Rahul. So when I know the granuloma formation, our goal is to understand microscopy. Microscopy is something which is amazing. You need not have mnemonics at all. You're going to read in a way that you'll understand how a granuloma looks, so that you'll never forget. Most of you are in second year, right? Tomorrow, if you have a pathology practical sometimes down the road, ask them a granuloma slide and verify whatever we are going to learn, right? Okay, now let's go to this. So the function of activated macrophage was to secrete, right? And they're going to secrete interleukins. I'm right in saying interleukins, right? Can I say interleukins are proteins? Yes, they secrete interleukins. Interleukins are primarily proteins, right? Generally, once the scarring happens, you will not be able to see the bacteria, right? They are proteins, and all the proteins are pink in color, right? I had a cell like this, a normal macrophage with a nucleus in the center. It's going to secrete lots of proteins, synthesize lots of proteins. Can I say if something is going to synthesize, the nucleus goes to the corner? It does go to the corner. So now a kind of nucleus goes to the corner, right? Because something is accumulating, it pushes them outside. I'll answer your question, Rahul. Give me a second, right? Like a plasma cell, what we saw, it just goes to the corner. And the entire cytoplasm is having interleukin 1, interleukin 12, and lots of them. So what happens is the color becomes pink in color. It becomes a pink color, and the nucleus, let's assume it's a blue nucleus, the nucleus being pushed to the corner, right? So this is how my activated macrophage will look in a microscopy. Elongated cell, nucleus pushed to the corner, and a pink color cytoplasm, right? Now let's assume you are the first pathologist. You saw this cell in a microscope. You didn't know what is a granuloma. You're the first person who saw this. I'm having, you'll have one epithelioid, one activated macrophage, or multiple in the TB granuloma. Multiple, right? They have multiple activated macrophage like this. All of them is having nucleus in the corner, and all of them are having a pink cytoplasm, because the pathogenesis is the same, right? So can I say this kind of looks like an columnar epithelium. If you remember in your histology, in your first year, you must have seen columnar epithelium, right? You have a cell with a basal nuclei and the cytoplasm on the top. Looks like, what is the suffix we use for like in medicine? We call it oid, right? So can I call it, this looks like an epithelial cell? I can. So I call it an epithelioid macrophages. So epithelioid macrophages is a name given to a macrophage which looks like an epithelial cell. A normal macrophage will not look like that. Only an activated macrophage looks like that. So can I say all these cells have similar structure and function? Is that statement right? They do have similar structure, similar function, right? So if you have similar structure and function, take your college. You might have 100 or 150 or 200 people in your college. Everyone is your friend, or only 5 people are your friends? Only a bunch of them are your friends, right? Close friends. You have multiple categories: unit mate, friends, close friends, best buddies, right? So we always gel only with like-minded people. So when I have hundreds of macrophages of similar structure and function, there is a possibility, I'm not saying always, there is a possibility that some of these macrophages can fuse with each other. Maybe it felt they are buddies and they fused with each other, right? So why Lalit? Get hold of someone. Okay? Okay, so when they fuse with each other, I will have multiple nuclei and the cytoplasm will be of the same color, right? It will be of the same color, it will be pink in color, right? There will be pink color cytoplasm with multiple nuclei because these are nothing but macrophages fused together, and we call this an giant cell. We call it a giant cell, or we call it a cluster of my epithelioid macrophages forming a giant cell. Again, this might happen, this might not happen. Sometimes I won't see them in microscopy, right? Not at all, Rahul. I always believe in one thing: you behave the same way, the friends will behave the same way. If someone is not behaving the same way, ignore. You'll have one more person. India is good in one thing: reproduction, right? 140 crore. You won't find a person, you will find multiple good people, right? Okay, let's come back to chronic inflammation. You're going to have a giant cell formation, right? So this is what happens in the granuloma: epithelioid cells plus giant cells. What is the function of these epithelioid and giant cells? They are going to secrete interleukins. What does interleukins attract? What does interleukin attract? Lymphocyte. Cricket. Little bit problem in Hindi, so please adjust. Okay. So lymphocytes comes into the play, right? How does lymphocyte look in a biopsy? It looks small, round and blue. That's what we saw in the first chapter in the RRR series, right? We know how a neutrophil looks: a bent nuclei, eosinophil, pink granules, lymphocytes, small round blue cells, macrophages, completely clear cytoplasm, right? So now let's look at a granuloma. This is a granuloma image. This is from Google. If you look at this, can I say the center part of the granuloma, I'm having predominantly pink color cell? Yes. And the corner of the granuloma, can I say they are all small round blue cells? They are small round blue cells, right? Ideally all of this started for a TB bacilli, right? So the center, I'm having all the epithelioid macrophages. Okay? At the epithelioid macrophages, there is a possibility it can become a giant cell here. क्रिकेट मेरा हिंदी थोड़ा ख़राब है, इसलिए मैं इंग्लिश से बोल सकता हूँ, तो थोड़ा एडजस्ट कर दीजिए. If you have any doubts, please ask in Hindi. I'll definitely be able to answer. Right? I did my PG from Jimma, Pondicherry, Class Corner. So you have an you might have a giant cell, you might not have a giant cell. In the center, it's predominantly your epithelioid macrophages, and the corner you'll have lymphocytes. Horseshoe arrangement, maybe there may not be, right? So this is what happens in granuloma formation. Right? This is the formation in most of the granulomas, whatever may be the etiology. I'm trying, Lalit. You're not teaching me Hindi. Today you have a job. You have to teach me one word in Hindi so that I won't forget it again. Okay. So your job, like I said, you go to your college tomorrow, take a granuloma slide, see if it happens like this. Okay, Shreya, epithelioid cells are formed in a very simple way. Vanakkam Nishant. See, I had activated macrophages. How it is formed is CD4 secretes interferon gamma. Interferon gamma converts a normal macrophage to an epithelial macrophage. And the function of any epithelial macrophage, here it changes to M1, it's secretion, that's all right. So it's going to secrete interleukin 1, interleukin 12, which brings again interferon gamma, which forms my epithelial macrophages. Why we call them epithelioids? The appearance, it looks like an epithelial cell, so we call them epithelioid cells, right? Okay, so this is how a granuloma is formed, right? Rahul, mixed celularity Hodgkin's and nodular sclerosis Hodgkin's. The reason why we call it nodular sclerosis, it will have fibrosis, looks like a nodule, so we call it nodular sclerosis. Mixed celularity, the main reason for calling it mixed celularity is the background WBCs will be like neutrophils, will be plasma cells, will be lymphocytes, will be eosinophils, multiple mixed cells in the background, so we call it mixed celularity Hodgkin's lymphoma. Fine. Okay, so that's about granuloma formation. I'll just leave it at one open-ended note. We have two types of granuloma. I'm sure in your college you must have started seeing slides. Tuberculosis, what type of granuloma you see in microscopy? Necrotizing or non-necrotizing? We call it caseating, right? We have caseating granulomas and we have non-caseating granulomas, right? Or necrotizing granuloma or a non-necrotizing granuloma. So this difference, you will learn a table, especially when you come to NEET or next PG exams, right? Yes, Rahul, it will be. You will definitely learn lots of things in the table. Any table you read going forward in medicine, please don't memorize the table. Any book will have a table. Read 1 or 2 pages before the table, because table is information. If you memorize information, you cannot retain. But if you know why the table is formed, it's very easy to revise, right? Please remember that, right? The basic is simple. It's caseating necrosis, right? Necrosis means cell death. Necrosis is equal to cell death, that's all. We know that. So which means if I have an organism dying in the granuloma, it's necrotizing. Okay. If there is no death, if there is no organism's death, it's non-necrotizing. That's a basic difference between necrotizing and non-necrotizing granuloma. Fine. So like Kamran said, TB, histoplasma, coccidiomycosis. Histoplasma and coccidiomycosis are fungal disorders. You will read them a little bit later in your microbiology, right? These are all necrotizing. Okay, Lalit, please put that in English also, so that's the word for me in learning in Hindi today. Fine. Okay. There's no organism death, it's going to be non-necrotizing. I'm just going to ask you one question. If my immunity is not so powerful, is there a possibility I cannot kill the TB bacilli? Yes, there is a possibility, right? So whenever you see granuloma, the first thing is tuberculosis. First thing is tuberculosis, right? That's what I want you to think about. Any granuloma you see in microscopy, necrotizing or non-necrotizing, till you are practicing medicine, rule out tuberculosis, because there is a possibility a person's immune system can be good. Okay, I kill the TB bacilli. A person's immune system is not good, I cannot kill. If I cannot kill, it will not have caseous necrosis, because TB necrosis is caseous necrosis, so it will be non-necrotizing, right? So anything you can't kill. Foreign body granuloma, is there any, can I kill a foreign body? Foreign bodies like coal, suture, can I kill them? It's already dead, right? I can't kill them. Sarcoidosis, there's nothing to kill. Again, non-necrotizing. There's something called Crohn's disease. We'll read when we come to intestine. Non-necrotizing. There are multiple places. You have Hodgkin's lymphoma. Again, non-necrotizing, right? So all these, the basic denominator is simple thing. No Kushal Saini. I don't know, that's what. So all these things, the basic denominators, there's no cell death. If there's no, please Rahul, can you repeat your question? If there is no cell death, it will result in no necrosis, so it will be non-necrotizing granuloma. If there is a cell death, it will be necrotizing granulomas. Any organism. Cat scratch is an organism, it will form necrotizing granulomas. Anything which is organism which my body can kill, it will cause necrotizing granuloma. There's no organism my body cannot kill, it will cause non-necrotizing granulomas. Fine. So that's a basic difference of necrotizing and non-necrotizing granuloma. Fine. I'll come to the end of the session. So we read about chronic inflammation and the types of granuloma formation today. Please go to your practicals and see it once, because once you see it, whenever you see it, you will be able to relive whatever you read, and please teach to your friend. That will make your concepts much more stronger. Kahas bata hai means, Rahul, please help me translate that. No, see, Rahul, your question is fibrosis will be seen definitely in every Hodgkin's lymphoma. See, let's take any I'll give you an example. Chronic inflammation. Can I say chronic inflammation can have fibrosis sometimes, can also have non-fibrotic places? It can have, right? There's a possibility both fibrosis and non-fibrosis can happen. So in that condition, same way, Hodgkin's lymphoma, one of the presentation is fibrosis. When fibrosis is predominant, I call it nodular sclerosis. If it's not there, no lymphocytes, lymphocyte depleted. More lymphocytes, lymphocyte rich. It's a variant. Not every Hodgkin's will have fibrosis. Some of them, fibrosis more. I have that subtype. That's how it is. Hello, FMG aspirant. Lalit, you have to teach me Hindi. I'll make sure this by the end of this year you will learn pathology and I'll learn Hindi, right? And like I said, no, I have a bit difficulty in explaining in Hindi. Rahul, mixed cellularity, the background is lots of mixed cells, so we call it mixed cellularity. Saini, MBBS doesn't have Hindi medium. Hopefully in future, the textbook will change from English to our country, but I don't know. Okay, see you soon in the next lecture. Till then, bye-bye. I think I'll have lecture in the next week again, so we'll see. Bye-bye. Thank you, Kul.